Hi, I'm Jeff Berry, editor of Positively Aware magazine, and we are here at the 17th Conference on Retroviruses and Opportunistic Infections. I can't even say that. That's the Retrovirus Conference, also known as the Retrovirus Conference. And I'm here with two doctors who are leading physicians in their field, and Joel Gallant on my right from the Johns Hopkins School of Medicine, and Richard Haubrich from UC San Diego. Welcome.
Thank you.
Thank you.
So we're here to talk about treatment update here at the Retrovirus Conference. And the first thing I wanted to ask you about was the new Merck compound MK1439.
Okay. So it's a new NNRTI. Appears to have some activity against some drug-resistant virus, including virus that has the 103N, the 181C mutations, which are common mutations for drugs like nevirapine, Viramune, or efavirenz, Sestiva, active at low dose, so it would be a promising drug for co-formulating with other products. And we saw some early data showing good activity. Looks to be fairly well tolerated. Richard, do you have any other?
Yeah, no, it was interesting. I had dinner last night with Daria Hazuda from Merck, and someone asked her, why are you developing another non-nuke? Why do we need another non-nuke? And so her answer was good. And, you know, efavirenz is a great drug, but some people can't tolerate it. Rilpivirine in Complera is a nice co-formulated drug, but still there's concern in that drug with people with high viral loads.
Right.
So what we really need is a drug that has the low side effects, low milligram amounts, so it can be combined, and still has good activity. So hopefully their in vitro work and preclinical testing suggests that it might meet those barriers, but we need to see in the clinic if it works out well. So that's, I think, why it's being tested.
And although I'm sure that it's going to be mainly studied in treatment-naive patients, it is encouraging that it seems to have activity against especially the 181 mutation, which a lot of our drugs don't do so well against. So there may be some benefit in treatment-experienced patients.
And where do you see like non-nukes such as Sestiva or Tripla, which has one in it, and so they are developing this new non-nuke, and do you think it's going to remain in the treatment paradigm for the near future? Is it with the new classes coming along?
Oh, I think so. I think there's certainly now a lot of competition against a tripla that didn't exist before, with Complera, with Stribild, and still with protease inhibitors. But you got to remember too that Sestiva or efavirenz will go generic soon, right. And there may in fact be quite a lot of pressure to use that as a first-line agent because it'll be a lot cheaper. So I don't think we're going to see that strategy go away anytime soon.
Yeah, I certainly agree. Non-nucleosides will be an important component, particularly of first-line regimens, and in second and other regimens too, paired with protease inhibitors.
Great. So next we have a Antiviral, which is not approved yet. So again, it has a name that's hard to pronounce, but it is a CCR5 antagonist, CCR5 dual antagonist, right? CCR5 and CCR2. So maybe you could explain to our viewers what that means, or if it means anything, or what the advantages might possibly be with that.
Well, CCR2 is associated with inflammation, and the idea of blocking CCR2 could have some anti-inflammatory properties that, in fact, in this study they did show some reduction in inflammatory markers. Now that's, of course, a long way from demonstrating that amounts to anything from a clinical standpoint, but there is some, at least hypothetical, advantage to blocking both CCR5 and CCR2. And CCR2 blockers are being looked at for their role in other conditions associated with inflammation, so there's certainly a rationale for it.
And the CCR5 antagonist that's currently available, Maraviroc or Cellsentry, people have looked for other activity besides just using it as an antiviral. It clearly works as an antiviral. And it hasn't quite worked out the way people had hoped in terms of these other, what we call off-target activities, meaning in addition to blocking the virus, also could reduce inflammation and have other potential benefits. And so I think this drug might be interesting in that category, but it's early at this point.
Yes, and so with the CCR5 antagonist, Cellzentry or Maravirac, that is currently available, you do have to take the tropism test, and that's been a barrier, I know, for uptake with that particular drug. So this would require a similar type of test. Do you see that the genotypic, the cheaper, essentially the barrier is that it's more expensive, the current test, and so there's a cheaper test that may be becoming available. Do you think that's coming soon?
It's available now. You can order it now through commercial laboratories,
Okay.
and it looks quite good.
Is that sufficient, though,
I think
via the
so.
label to?
Yeah, I don't know, Richard.
The data clearly shows that depending on the type of genotype test, and I'm not as familiar with the one that's commercially available, but certainly some of the work that's been presented and published by the BC Richard Harrigan group with more deep sequencing, those have are sensitive enough to pick up low levels of non-R5 virus. So all of the R5 antagonists work against R5 virus only. And so if there's small amounts of non-R5, what we call X4 virus, then those viruses won't work. Or sorry, those drugs don't work. And so the more sensitive assays clearly, I think, look very promising.
And this assay that we can order now, what it does is it does a quick genotypic tropism analysis. If it finds dual mixed or X4 virus, then you'll find that out. But if it doesn't, if it finds only R5, it then reflexes to an ultra deep sequencing to look more carefully for the presence of dual mixed and X4, and that's the one that we've been using as opposed to the phenotype.
And so the cost is even with
more
that,
like a genotype, more like a standard genotype. I don't know exactly
Yeah.
what it is, but it's certainly a lot cheaper than the tropism assay, the phenotypic tropism assay that we've been using before.
but you still have to wait. So a person has to have detectable viral load.
You
Correct.
do, right. So if you want to do it if you need tropism on somebody with an undetectable viral load, you still have to use the Trofile DNA assay, which is more expensive.
And there's a weight about what?
I think for the Trofile, it's at least 2 to 3 weeks.
Yeah, 2 to 3 weeks.
So those are
Faster
those are
with the
pretty
genotype.
significant barriers still for that kind of a drug, right? It has to be a specific population that has a viral load and would be willing to wait to initiate treatment.
I mean, if you imagine some point in the future where we're using these drugs for first-line therapy, everybody gets a genotype already, and that takes a couple weeks to get back. So you could imagine that if there was some strong rationale to use a CCR5 antagonist in first-line therapy, you'd simply combine your baseline genotype with a baseline tropism genotype. It would all maybe be bundled together, and you'd be waiting that amount of time anyway. So it wouldn't really add to the wait. And we're not there yet, of course, and we don't have strong rationale right now to use these drugs first line. But it wouldn't be unreasonable if there was some good reason to do it.
Great. Well, that's encouraging. So next I wanted to ask about the study that was presented here at this conference showing it's a new version of tenofovir, which is found in Truvada or Viriad, but it's a prodrug. It's also another prodrug of the same, what we call TDF now. This one is called TAF, and it was also part of the combination that was recently approved, co-formulated one single tablet regimen, Stribild. And so they're basically comparing two versions of Stribild, the current one that's available, and a new one which has this one drug with a new formulation that's, so maybe you could talk a little bit about that.
So the tenofovir that people take now, whether it's in the form of Viriad, Truvada, Stribild, Atripla, Complera, is not really, it's tenofovir DF. And it's what we call a prodrug, and it turns into tenofovir after you take it. TAF, and I'm not going to try to pronounce what that stands for, TAF or TAF is another prodrug that turns into tenofovir. But you get you get higher levels of tenofovir in the cell and lower levels in the plasma. And the potential advantage of that would be less toxicity. The toxicities we worry about with tenofovir DF are kidney and bone. And so the other advantage is that you actually can use a much smaller amount of it, which gives it has advantages in terms of combining with other drugs into single tablets. So this study, as you said, compared Stribild with this other Stribild-like combination that uses TAF instead of TDF. So one tablet versus one tablet. And they showed that both of them work quite well, but there was a little evidence that the kidney function was less affected with TAF than with TDF, and that there was less of a decrease in bone density with TAF compared to TDF. So it shows that there does appear to be promise with this, and they're now enrolling in phase 3.
Yeah, and I think that there was another presentation just looking at standard commercially available tenofovir in women in an African setting that showed that particularly when you use it with a boosted PI, in this case Kaletra, again, there was a little more renal side effects with the current tenofovir. So the promise of the TAF is that that could be less, and eventually it'll be easier to formulate with lots of different regimens and require less monitoring in a resource-limited setting where it's hard to get creatinines every 3 to 6 months if you need to.
Which is a real need out there, obviously, because there are people with these underlying renal issues, and so they're looking for hopefully something that they won't have to worry about as much. Hopefully, Richard, maybe you could tell us about these. There's a new integrase that's being developed by ViiV, dolutegravir, and that's looks like it's. All the studies are showing really great activity, and so I think there was poster on a study called Sailing here versus Icentris or raltegravir.
Yeah, so that study really showed smooth sailing for dolutegravir. And so that study looked at dolutegravir not for use in naive patients, but now in treatment-experienced patients who are using an integrase inhibitor as part of a new regimen when you need it for salvage therapy. And it compared dolutegravir to raltegravir in a very good study design. And the bottom line results showed that dolutegravir actually did a little bit better than Icentris. It was really pretty surprising. A small margin, but statistically significant. And with the same safety profile as Icentris, which we know is a great drug for its safety. Dolutegravir can be taken once a day. It's a small milligram amount. Again, co-formulations are in the pipeline. So it suggests that both in treatment-naive patients and now in experienced patients, dolutegravir looks very promising.
We're finally beginning to see a little resistance to dolutegravir in that study. They found for once, they found a mutation that we hadn't really seen in treatment-naive studies.
Yeah, so the previous studies had really failed to show integrase inhibitor resistance to this drug, and so the question is, does it have a higher barrier to resistance? But now in a more challenging setting, that is in one of patients that have underlying drug resistance, putting together a salvage regimen, we saw it, although less than with the Icentris.
Mm-hmm. And was that a mutation that's commonly found with those drugs, that class, the Icentris?
I think it's one that's been seen with elvitegravir, but it's not a common mutation.
One,
certainly not with Icentris.
And I think there were 2 patients that had it.
Yeah.
So. Okay. Still a little bit early to know.
And of course, we expect this drug to be approved soon.
Yes.
And then,
August 17th, I think, is the
right?
PDUFA date.
Okay.
Which is like the drop dead kind of.
Okay. And
so the date they promise if everything goes well. Unless if they find something, then they say, well, maybe it'll be a little longer.
So hopefully look for but that's as a standalone.
That's as a standalone, not in co-formulation.
But it is once a day, doesn't require boosting. So
and then we expect there to be a co-formulation to follow that will combine it with the ingredients of Epsicom, which are abacavir and 3TC together with dolutegravir. So that will be our first non-tenofovir based single tablet regimen, which has some advantages in the sense that not everybody can take tenofovir.
Right.
So.
That's a good point. Speaking of not taking something, so there's a study that Richard, you're I think, involved in, or
yeah. So
the option study.
The option study is a study that I was the co-chair with Karen Tashima, who presented it, and she did a lovely job, and she's much better looking than me, so everybody was happy. Yeah, there you go. So in this study, we asked the question in more highly experienced patients, so those that have been not on one treatment, not on two, but have been on all of the 3 first-line treatments, so nukes, non-nukes, and PIs. Do we need to continue to use nucleosides? So every regimen so far that we've designed that's been tested in all the big studies has used nukes. All of the salvage regimens the studies that have looked at Icentris, that looked at Prezista, all of those studies included nucleosides in the regimens. So we asked the question, now that we have more drugs that can work against drug-resistant virus, more classes of drugs like the integrase inhibitors and the R5 antagonists, can we get away without using the nukes? Do we need to continue to have 4 and 5 drug combinations for our highly experienced patients? So the study took people that had 3-class experience and or resistance to the nukes, non-nukes, and PIs, and randomized them to get a new regimen. And the regimen was individually designed for every individual patient. So everybody got the best resistance test, tropism test, paid for by the study. And then the study committee looked at all the data we had and recommended regimens, as many as we could, that would give enough active drugs. So they had to have more than 2 active drugs and at least 3 drugs. And that was their study regimen. Once they picked that out, they were randomized to get that either alone or with nucleosides. And again, we used the resistance test to use the best available nucleosides for those patients. The study was designed to show that leaving the nukes out was as good as using the nukes, and that's what we showed. The primary endpoint was viral failure or stopping nucleosides or adding them if you were randomized not to have them, and we showed non-inferiority, meaning it was just as good. And all the sub-analyses, including viral failure, was just as good if you didn't use nukes as not. So the conclusion from the study was that you can design a regimen in 3-class treatment-experienced people. That regimen can exclude nucleosides and still do well at suppressing the virus, suggesting that we can use fewer drugs with less toxicity, potentially, and less cost.
Yeah, I'm so glad it came out the way it did, because I think there was this kind of belief that there was something magic about nucleosides, and if you tried to design a salvage regimen without them, people were a little bit shocked that you would do that, and yet you have 2 or 3 fully active drugs. It just didn't make sense, so I'm glad that common sense prevailed.
Yeah, I mean, we've been looking for a while for nuke-sparing regimens, and the combinations we've used so far either worked but were too toxic or had more viral failure, and so this really just enhances the concept that you can design a nuke-sparing regimen if you have enough active drugs. And that caveat is very important, obviously.
So what does that mean clinically for, how would that pan out? How many would you guess are people that are still sensitive to that class of drug if they're that experienced?
Yeah, so the question is, well, fortunately now, most of the people we see starting on medicines don't have that degree of drug resistance. So they would start on a simpler regimen, a fixed-dose combination like a Tripla or Complera. And as the number of options there is continuing to increase. But people who have been on multiple regimens, either because they had transmitted resistance or they just didn't take them well enough and acquired resistance, then we know that if you design the regimen well, if they have a lot of nucleoside resistance, there's no point necessarily in continuing that.
I know we only have a few more minutes, but there was another study, Richard, that you wanted to talk about.
Sure, yeah. This was more not a randomized study, but getting towards the prevention. And so we know that if we get people on therapy, they get their virus suppressed, then their risk of transmitting to other people goes down. This study looked at people in San Diego who were on an antiretroviral regimen, had low-level or completely suppressed virus, and asked, is there virus in the genital compartment in men? So they were all men. We looked at 115 patients, and we found two things. There was overall an 11% rate of people who had a detectable virus in their semen, meaning that there still is some risk of transmission even in people on therapy who are suppressed. Now, of course, those that had little blips of virus between 50 and 500 were more likely to have the virus in their seminal plasma. But the other sort of interesting thing from a scientific standpoint is we found that those people that also had CMV in the genital plasma, which can happen in people with HIV, can happen even in people who don't have HIV, that increased the risk of having HIV in the genital plasma. So as we move towards cure and trying to keep people from transmitting virus to others, looking for factors that are associated with virus in the genital plasma is important.
And finally, I wanted to talk just real briefly, Joel, maybe you could tell us about the VOICE study here. It's a study that had 3 arms in it that was looking at different methods of prevention.
Yeah, a very important study and a very disturbing study in a way. It was a very large study conducted in Africa. Jeannie Marazzo presented the data. 3 different arms in African women. One was a tenofovir vaginal gel used daily. One was tenofovir as PrEP or Viriad, and the other was Truvada as PrEP. The first 2 arms had already been stopped by the DSMB for lack of efficacy, so the only remaining arm was the Truvada PrEP versus placebo, and it didn't work either. And when it came down to looking at why it didn't work, it was very clear that the women in the study simply weren't taking it. They brought the right number of pills back. They reported adherence, but they didn't have tenofovir in their blood, and so it's very.
Some didn't even had never shown it.
Not even from day one.
Not ever taken it.
So it raises all sorts of questions. And one of the very disturbing things was that the risk of HIV in these women was so high, and that the women who were at the greatest risk were the ones least likely to be taking the meds. And we've seen this before in the FemPrep studies, that women who were at very high risk for HIV acquisition rated their risk as low. So women were assuming they were at low risk, but in fact were high risk, and many women got infected in this study. So it's going to take an army of behavioral scientists to figure this out, because what these studies are telling me, all of them in aggregate, is that PrEP is a great tool for individuals who want to protect themselves, but it's not going to be an effective tool on a population level to change the course of the epidemic, unless we figure out what it is that causes these adherence problems.
All right, so the take home on that is adherence.
Yeah.
So once again, I want to thank our guests, Dr. Joel Gallant, Dr. Richard Haubrich. Thank you so much for taking time out of your busy schedules here at CROI. And I want to thank our viewers for watching. Thank you.